hello everyone. Hope you are doing well. Welcome to Deepti's Academy. My name is Deepti. Today we'll discuss about an important topic, multiple sclerosis. Before moving into the topic, I would like to request you to like the video, share the video with your friends. If you have any doubts or comments, please mention in the comment box. And thank you as you remember to subscribe my channel. We will begin by discussing the basic structure of the nerves. An individual nerve cell is also known as neuron is made up of small branching extensions called dendrites, a cell body and an axon which is one single long branch. At the end of the axon we find the axon terminals. Let's see multiple sclerosis. What is multiple sclerosis? It's a chronic, progressive, non-contagious, degenerative disease of the central nervous system characterized by demyelination of the neurons. It usually occurs between the ages of 20 to 40 years and consists of the periods of remissions and exacerbations. The cause is unknown, but the disease is thought to be the result of an autoimmune response or viral infection. Now, let's have a comparison of nerve cell that is affected with multiple sclerosis with that of a normal nerve cell. You can see a damaged myelin sheath. The immune system attacks the myelin, the protective layer around the nerve fiber, and cause inflammation and lesions. This makes it difficult for the brain to send signals to the rest of the body. Let's see the precipitating factors of multiple sclerosis, which include pregnancy, fatigue, stress, infection, and trauma. Electroencephalographic findings are abnormal. Electroencephalography is an electrophysiological monitoring method to record electrical activities of the brain. It's a typical non-invasive with the electrodes placed along the scalp as shown in the picture. Throughout the procedure, the electroencephalograph machine makes a continuous graphic record of the patient's brain activity or brain waves on a long strip of recording paper or on a computer screen. Assessment of lumbar puncture indicates an increased gamma globulin level, but the serum globulin level is normal. Next is ataxia and vertigo. Ataxia is a loss of muscle control in the arms and legs. Ataxia may cause the patient to lose the balance and walk with unsteady gait. The patient may feel dizzy, clumsy, and unable to coordinate and control the movements. In multiple sclerosis, inflammation attacks and damages the nerve fibers and myelin, a protective tissue around the nerves in the brain and spinal cord. Eventually, nerve cells that control the movements by sending and receiving electrical signals are damaged. Nerves cannot communicate with each other normally to control the body movements. People with multiple sclerosis may have one or more of the three types of ataxia. They are cerebellar, sensory, and vestibular. Cerebellar ataxia is caused by damage to the cerebellum in the back of the brain, above the brainstem and neck. Neurons inside the cerebellum control the voluntary muscle movements to help to stand, balance, and steady. Multiple sclerosis inflammation can lead to lesions or scarred areas in the cerebellum or other parts of the brain that are connected to the cerebellum. This can cause disruptions to the actions of different nerves that control the muscles and movements on one or both sides of the body. Next is sensory ataxia. Sensory ataxia is also called as proprioceptive ataxia. It's a loss of sensitivity in the movement of the joints, limbs, and other body parts. Sensory ataxia is caused by damage to the nerves in the dorsal column in the back of the spinal cord. These nerves carry messages to the brain that regulate how the patient positions the body parts and limbs. Sensory ataxia may also be caused by changes in parts of the brain where nerve messages are received, like cerebellum, thalamus, and parietal lobe. The brain confuses messages about proprioception or how to position the body within a space when the patient moves. Lastly, we have vestibular ataxia. Vestibular ataxia is caused by damage to the vestibular system, such as the inner ear structures and fluid-filled ear canals that control the sense of balance. Vestibular ataxia may also happen if multiple sclerosis causes lesions on the brainstem or vestibular system parts, or if multiple sclerosis damages nerves that connect tiny organs in the inner ear that control balance. Vestibular ataxia causes vertigo, loss of balance, dizziness, nausea, vomiting, and eye jitters or twitches. Some people with multiple sclerosis develop vestibular ataxia slowly, so that they have just a loss of balance or equilibrium, not other severe symptoms. Next assessment is tremors and spasticity. Tremor is an important and common symptom in patients with multiple sclerosis. Tremor or shaking that the person cannot control is a common symptom of multiple sclerosis that usually develops after at least 5 years of having the disease, though this is not a hard and fast rule. Tremors can occur when the person is trying to do something with the hands, whether standing or sitting, and their severity can range from barely noticeable to significantly interfering with their daily task. Next is spasticity. Spasticity can cause pain and sensation of muscle tightness. However, the signs and symptoms are highly variable and may include reduced range of motion, difficulty relaxing or releasing the muscles, increased deep tendon reflexes, and clonus. How does clonus can lead to spasticity? Clonus is a repetitive movement of a hand or foot. It's a neurological condition that occurs when the nerve cells that control the muscles have become damaged. This damage causes involuntary muscle contractions or spasms. Next is paresthesias. Multiple sclerosis is a tingling sensation or numbness that most multiple sclerosis patients experience. The majority of sufferers have complained of paresthesia multiple sclerosis at some point, and this is one of the most common multiple sclerosis symptoms. Although symptoms like tingling and numbness may sound like minor problems, paresthesia multiple sclerosis can actually be very painful and can affect the patient's mobility. These are caused by lesions on the spinal cord that affect the central nerve system, while also causing severe pain in the nerves, tingling sensation, and patches of skin where the sensation is lost. The next clinical manifestation that we need to assess are blurred vision, diplopia, and transient blindness. Blurred vision. One of the most common early signs of multiple sclerosis is vision problems, clinically called as optic neuritis. Inflammation affects an optic nerve and disrupts a person's central vision. This can lead to blurred vision in one or both eyes, sometimes double vision, or loss of contrast or vivid colors. Pain can also accompany the loss when a person looks up or to one side. Double vision, also known as diplopia, can occur in multiple sclerosis when the nerve pathways that control the eye movements are damaged. The vision in each eye is usually normal, but the nerve damage means that the eyes are not aligned properly. So the vision messages from each eye are not coordinated and the person can see a double image. Transient blindness is a symptom that can come and go sporadically throughout the progression of multiple sclerosis. It can be caused by nerve damage due to the demyelination process. Certain nerves can be damaged by demyelination, including nerves that send signals to and from the eyes and brain. Nystagmus. Multiple sclerosis nystagmus symptoms include unusual and often jerky eye movements caused by damage to the optical nerve. Sometimes in multiple sclerosis nystagmus, the eyes will jerk from side to side or up and down, while in other cases they may roll around in a clockwise or anti-clockwise movement. Dysphasia or aphasia is the medical term for difficulty in finding the right words or forming sentences. In multiple sclerosis, this is caused by disruptions in the parts of the brain that control the thought, short-term memory, verbal fluency, and attention. Next assessment, decreased perception to pain, touch, and temperature. Bladder and bowel disturbances including urgency, frequency, retention, and incontinence. Abnormal reflexes including hyperreflexia, absent reflexes, and a positive Babinski reflex. We need to assess the emotional changes too, such as apathy. It's characterized by lack of emotion and feelings of indifference, euphoria, extreme feeling of pleasure, happiness, and excitement, irritability, and depression. And finally, memory changes and confusion. Here are the interventions for multiple sclerosis. First one, provide energy conservation measures during exacerbation. Second, protect the client from injury by providing safety measures. Place an eye patch on the eye for diplopia. Monitor for potential complications such as urinary tract infections, calculi, pressure ulcers, respiratory tract infections, and contractures. Promote regular elimination by bladder and bowel training. Encourage independence. Assist the client to establish a regular exercise and rest program and to balance moderate activity with rest periods. Assess the need for and provide assistive devices. Initiate physical and speech therapy. Instruct the client to avoid fatigue, stress, infection, overheating, and chilling. Instruct the client to increase the fluid intake and eat a balanced diet including low fat, high fiber foods and foods high in potassium. Instruct the client in safety measures related to sensory laws such as regulating the temperature of bath water and avoiding heating pads. Instruct the client in safety measures related to motor laws such as avoiding the use of scattered rugs and using assistive devices. Finally, instruct the client in self-administration of prescribed medications. Hope you understand the interventions for the patients with multiple sclerosis. Now, let's move on to the questions that may come under multiple sclerosis. First question. The home health nurse has been discussing interventions to prevent constipation in a client with multiple sclerosis. The nurse determines that the client is using the information most effectively if the client reports which action. Let's see the options. Option number 1, drinking a total of 1000 ml per day. Giving herself an enema every morning before breakfast. Third option, taking stool softeners daily and a glycerin suppository once a week. Fourth option, initiating a bowel movement every other day, 45 minutes after the largest meal of the day. Let's see the options one by one in detail. First, drinking a total of 1000 ml per day. To manage constipation, the client should take a high fiber diet, bulk foamers and stool softeners. A fluid intake of 2000 ml per day is recommended. So the option number 1 is wrong. Let's move on to the option number 2. Giving herself an enema every morning before breakfast. Laxatives and enemas should be avoided whenever possible because they lead to dependence. So option number 2 is wrong. Taking stool softeners daily and a glycerin suppository once a week. A glycerin suppository, viscodile suppository or digital stimulation may be used to initiate the process. Laxatives and enemas should be avoided whenever possible because they lead to dependence. So option number 3 is wrong. Option number 4. Initiating a bowel movement every other day, 45 minutes after the largest meal of the day. The client should initiate a bowel movement on an every other day basis and should sit on the toilet or commode. This should be done approximately 45 minutes after the largest meal of the day to make advantage of the gastrocolic reflex. So option number 4 is right. Second question. A client with multiple sclerosis is experiencing muscle weakness, spasticity, and an ataxic gait. On the basis of this information, the nurse should include which client problem in the plan of care. The nurse has to find out the most appropriate interventions in the plan of care. Let's see the options. First, inability to care for self. Option number 2, interruptions in skin integrity. Third option, interruption in physical mobility. Fourth option, inability to perform daily activities. As we discussed before, multiple sclerosis is a chronic, non-progressive, non-contagious, degenerative disease of the central nerve system characterized by demyelination of the neurons. Interruptions in physical mobility is most appropriate for the client with multiple sclerosis experiencing muscle weakness, spasticity, and ataxic gait. The options inability to care for self, interruptions in the skin integrity, and inability to perform daily activities are wrong as they are not related to the data in the question. So our answer is interruptions in physical mobility. Let's see the next question. Question number 3. A client is admitted with an exacerbation of multiple sclerosis. The nurse is assessing the client for possible precipitating risk factors. Which factor, if reported by the client, should the nurse identify as being unrelated to the exacerbation? Here are the options. Option number 1, annual influenza vaccination. Option number 2, ingestion of increased fruits and vegetables. Third option, an established routine of walking 2 miles each evening. The last option, a recent period of extreme outside ambient temperatures. The onset or exacerbation of multiple sclerosis can be preceded by a number of different factors including physical stress, for example, vaccination or excessive exercises, emotional stress, fatigue, infection, physical injury, pregnancy, extremes in environmental temperature, and high humidity. No methods of primary prevention are known. Intake of fruits and vegetables is a healthy and an unrelated item. Hence, we must say the options annual influenza vaccination, an established routine of walking 2 miles each evening, and a recent period of extreme outside ambient temperatures are wrong. So, our answer is ingestion of increased fruits and vegetables. Question number 4. The nurse is planning care for the client with a neurogenic bladder caused by multiple sclerosis. The nurse plans for the fluid administration of at least 2000 ml per day. Which plan would be the most helpful to the client? Here, the nurse has to plan properly by dividing the total fluid intake in a day to help the client to overcome the effect caused by neurogenic bladder. Let's see the options. Option number 1, 400 to 500 ml each meal and 500 to 600 ml in the evening before bedtime. Option number 2, 400 to 500 ml with each meal and additional fluids in the morning but not after midday. Option number 3, 400 to 500 ml with each meal with all extra fluid concentrated in the afternoon and evening. Option number 4, 400 to 500 ml with each meal and 200 to 250 ml at mid-morning, mid-afternoon and late afternoon. What is neurogenic bladder? Neurogenic bladder occurs when transmissions between the brain and the bladder are damaged or interrupted. In case of multiple sclerosis patients, the disease's effect on the brain through the development of lesion leads to the progressively worsening body functions, quite often in lower extremities. The treatment of neurogenic bladder in multiple sclerosis is through the use of bladder training. This helps the patients to manage the bladder dysfunction by scheduling bathroom visits and controlling the diet and fluid intake. So, spacing fluid intake over the day helps the client with a neurogenic bladder to establish regular times for successful voiding. Omitting intake after the evening meal minimizes incontinence or the need to empty the bladder during the night. So, option number 4, that is 400 to 500 ml with each meal and 200 to 250 ml at mid-morning, mid-afternoon and late afternoon is the right answer. Next question. A client with multiple sclerosis tells a home health care nurse that she is having increasing difficulty in transferring from bed to a chair. What is the initial nursing action? What does the nurse must do first after listening to the client's problem? Let's see the options. Option number 1. Observe the client demonstrating the transfer technique. Option number 2. Start a restorative nursing program before an injury occurs. Option number 3. Seize the opportunity to discuss potential nursing home placement. The last option. Determine the number of falls that the client has had in recent weeks. Let's see the options in detail. Option number 1. Observe the client demonstrating the transfer technique. Observation of client's transfer technique is the initial intervention. Mostly this may be the answer. Anyways, let's see the other options. Option number 2. Start a restorative nursing program before an injury occurs. Starting a restorative program is important, but not unless an assessment has been completed first. So option number 2 is wrong. Let's see option number 3. Seize the opportunity to discuss potential nursing home placement. Discussing nursing home placement would be inappropriate in view of the information provided in the question. So option number 3 is wrong. Let's see option number 4. Determine the number of falls that the client has had in recent weeks. Determining the number of falls is another important intervention, but observing the transfer technique should be done first. So option number 4 is also wrong. Hence, we must say the first option, that is observe the client demonstrating the transfer technique, is the right answer. Hope you understand the topic multiple sclerosis and related important questions. I would like to request you all to like this video, share the video with your friends, and do comments in the comment box below if you have any doubts. And thank you as you remember to subscribe Deepti's Academy. See you soon with another important topic and related questions. Till then, take care. Thank you.